Good evening and namaste. Today we are going to talk about cardiac emergencies, basic facts and figures in primary care. What a practitioner should know about these cardiac emergencies and how they can tackle and what type of first aid they have to do. So to update the basic knowledge, we are presenting this presentation, cardiac emergency in primary care. You know, the burden of cardiovascular disease is one of the leading cause of morbidity and mortality from non-communicable disease worldwide. An estimated 17.9 million people died of cardiovascular deaths in 2016, representing 31% of all global deaths. In India, the estimated prevalence of cardiovascular disease was 54.5 million. 1 in 4 deaths in India are now due to cardiovascular deaths, especially ischemic heart disease, and stroke responsible for more than 80% of this burden. What are these cardiovascular emergencies? One of the most common and serious emergencies presenting to the emergency department. It is a life-threatening medical situation that involve the heart and require immediate and medical attention. That is why every one of the practitioners should be aware of these emergencies and how to tackle. It may present as a hypotension, low BP, or severe hypertension, chest pain, breathlessness, abnormal heart rhythms, or cardiac arrest. Acute ST elevation, myocardial infarction, cardiogenic shock, and out-of-hospital cardiac arrest are the most life-threatening cardiovascular emergencies we come across. What are the common signs and symptoms in cardiovascular emergencies? Chest pain, breathlessness, palpitation, sweating, pedal edema, or generalized edema. These symptoms may suggest and people must suspect that it may be an emergency. That can lead to hypotension, revised jugular venous pressure, cyanosis, basal crepitations, muffled heart sounds, pericardial rub, decreased breath sound, abdominal distension, pedal edema, splinter hemorrhage, and osteal nodes. So these are the signs, and the symptoms are already I told you: chest pain, palpitation, etc. A systematic approach to cardiovascular symptoms. That is, first, we have talked about chest pain. So how do you approach a chest pain? Chest pain is a common symptom seen in the emergency. Serious cause of chest pain must be identified and treated promptly to avoid severe consequences. Physicians may order a variety of tests to ensure patient safety. Lack of confidence in decision-making and unnecessary referrals to other specialties can lead to delayed treatment and longer hospital. We talk about golden hour in an emergency. What are the differential diagnoses of the chest pain? First of all, cardiovascular disease chest pain, acute myocardial infarction, acute coronary ischemia, aortic dissection, cardiac tamponade. The cardiovascular emergent diagnosis will be critical diagnosis and emergent diagnosis: unstable angina, coronary spasm, Prince-Metal angina, cocaine-induced pericarditis or myocarditis. Now coming to the pulmonary causes of chest pain: tension pneumothorax, pulmonary embolism. And then respiratory mediastinitis and pneumothorax also can produce chest pain. GI, this boroesophageal rupture, Mallory-Weiss syndrome, cholecystitis, and pancreatitis also can produce chest pain. How do you approach chest pain? First of all, the clinical examination and clinical history is very important. Nowadays, people don't spend time on the clinical history and examination, which is a forgotten art. You should ask important question, and by getting the history itself, one can, suspect or arrive at certain diagnosis. If they say chest pain, what is the onset of pain? What is the character of pain? What is the severity of pain? The duration. Is the pain associated symptoms like sweating or breathlessness? Is the pain radiating? The location of pain. What are the factors which aggravate the pain? Risk factors such as diabetes, hypertension, smoking, hyperlipidemia, the cholesterol, family history, ethnicity, and age above 40 years. All the risk factors. Now, how do you go about examine? I told you clinical examination is very important. Even though in the modern era, we got sophisticated equipments, but still don't forget the basic things like history and examination. When we were students, we were taught about physical examination, inspection, palpation, percussion, and auscultation. Kindly follow the same. First of all, you see the pulse, whether it's tachycardia, the pulse rate, myocardial infarction, or any coronary ischemia, myocarditis, pericarditis, aortic dissection. Then bradycardia may be due to acute myocardial infarction or coronary ischemia or unstable angina. Hypertension, acute MI, coronary ischemia or aortic dissection. Hypotension, severe massive MI, heart failure, aortic dissection, myocarditis, pericarditis, and coronary ischemia. So when you check the blood pressure, when there is hypotension or hypertension, you must correlate all these diagnoses. When there is a hypoxemia, it may be due to pulmonary edema or heart failure, pneumothorax, or pulmonary embolism or massive effusion. If there is a fever, usually the myocarditis and pericarditis, even after myocardial infarction, one can get fever, medial sternitis, and pulmonary embolism. Sweating, diaphoresis, acute MI, aortic dissection, coronary ischemia, unstable angina. You may have respiratory distress in acute MI or pulmonary embolism or heart failure. So what are the examinations you do? You check the pulse in both the hands. You check the blood pressure in both the hands. Any murmur, any gallop, any pericardial rub. Look for raised JVP. And when you do the respiratory, you see unilateral, decreased or absent breath sound. In abdominal, any epigastric tenderness and focal neurological deficit or any abnormality. What are the investigations you do? Patients presenting with chest pain should be investigated for ECG, X-ray chest, arterial blood gas, echocardiography, PQ scan or CT angiography, ultrasonography, positive cardiac markers. When you do all these tests like arterial blood gas, you can rule out lung pathology. And ECG can reveal ischemia, infarction. Echo will reveal whether the patient wall motion is right, whether they go for any heart failure. So nowadays we do CT angiography and then ultrasonography and the cardiac markers like BTNP. All this will give an idea what the patient is having. How do you manage? Proper history and examination is crucial for narrowing down the differential diagnosis. And as I said, some good investigation to reach a conclusion. Patient presenting with acute coronary syndrome or myocardial infarction should be timely referred to cardiology for possible early PCI because it's a golden hour. You door to needle time, you can give reperfusion by thrombolysis. If there is no facility for PCI, you can do thromboembolysis, or you can nowadays we do thrombolysis and followed by PCI. So it is called pharmaco intervention, investigation, pharmaco, that is both the thrombolysis and followed by intervention. So pharmaco intervention is also nowadays possible in the centers where these facilities are available. With patients with moderate high risk should be admitted to cardiology care even if the initial labs are normal. If you have a strong suspicion, don't send the patient away. Suppose the patient has got chest pain, radiating, sweating, all clinical signs suspect, and even if the ECG is normal, you keep the patient for observation and repeat the ECG. Then comes to breathlessness. How do you approach breathlessness? We talked about chest pain. Now, breathlessness is also a very serious symptoms. Chest pain and breathlessness can indicate both benign and serious underlying conditions that can lead to death within minutes to hours. Good medical knowledge, anticipation of problems, detailed medical history and examination are necessary for proper diagnosis and management. Choosing the appropriate investigation and timely disposition are crucial for saving lives. What are the different diagnoses of breathlessness? Cardiovascular, acute MI, pulmonary edema, cardiac tamponade, respiratory, tension pneumothorax, epiglottitis, anaphylaxis, ventilatory failure, airway obstruction, pulmonary embolism in a trauma, flail chest. Metabolic cause, toxic injection, diabetic ketoacidosis, neuromuscular, cerebrovascular accident, intracranial insult, organophosphate poisoning, miscellaneous like carbon monoxide poisoning, and acute coronary syndrome. The different diagnosis, emergent diagnosis are pericarditis, myocarditis. In a respiratory, I already told you pneumothorax, hemothorax, asthma, pneumonia, aspiration, and carpal nail. Neuromuscular, multiple sclerosis, Guillain-Barré, myasthenia gravis, tick paralysis. When you see the increased respiratory effort, the mechanical interference, hypotension, bowel obstruction, renal failure, electrolyte abnormalities, metabolic acidosis, diaphragmatic rupture, and anemia. When you see a patient who is breathless at rest, when their accessory muscles are put into action, when there is a tachypnea, you kindly get a good history, do the proper investigation to arrive at the conclusion so that you can immediately treat the patient. Okay, what is the history importance in this onset of breathlessness? Duration of breathlessness. Is it related to trauma? Does it change with the position? What are the aggravating and relieving factors? Breathlessness with other symptoms. Examination, I told you, tachypnea may be due to pulmonary edema, pneumonia, pneumothorax, obstructive and restrictive respiratory and cardiac causes. And then hypopnea, it can be seen in respiratory depression due to neurological state, neurological causes or toxins, tachycardia and pulmonary embolism, drugs and toxins, infections, tension pneumothorax, trauma, lung contusion. Hypotension may be due to pneumothorax, cardiac tamponade. There may be fever or infections like pneumonia, myocarditis, malignancy. General appearance, you see whether the patient is pregnant, obesity, barrel chest, sleeping position, tripod positioning, bruises, or crepitations. You see the skin, nails, and hands, wasting of hands, tremors, clubbing. It may be bronchiectasis or malignancy. You see the neck. If there is any laryngeal spasm, stridor. And cardiac, you see the murmur, gallop, then muffled heart sound. Any wheeze or rales, hemoptysis, chain strokes, periodic breathing, subcutaneous emphysema. Of course, neurologically, you may have focal deficit, diffuse weakness, hyporeflexia, ascending weakness. Extremities, you look for deep vein thrombosis, edema of legs due to chronic heart failure. What are the investigations? Of course, you do chest X-ray, arterial blood gas, positive cardiac markers, PQ scan, CT scan, pro-BNB to rule out heart failure, D-dimer to rule out pulmonary embolism, Doppler, ultrasound, echo, and ECG. How do you manage? Serious cardiac emergencies can present as breathlessness, such as pulmonary edema, pulmonary embolism, MI, and cardiac tamponade. Prompt diagnosis and timely management is essential. Emergency requires specific management tailored to the patient's conditions. Patient with serious medical emergency should be admitted to medical ward or ICU, depending on the severity of the problem. Now come to palpitation. We have talked about chest pain, breathlessness. Then how do you approach palpitation? Again, palpitation can be a symptom of serious cardiovascular. Causes of palpitation, it can be anxiety neurosis also, sinus tachycardia, or it can be due to IHD, metabolic endocrine disorders, drugs, malignancy, inflammatory and infiltrative disorders, connective tissue disorders, and environmental factors. For hyperthyroidism, you may have a palpitation. It can be caused by irregular, abnormally fast or slow conduction system across the myocardium. You can have SVT or ventricular tachycardia. ECG can reveal very fast or slow rhythm, regular or irregular, short PR, prolonged QT, short QT, broad QRS, narrow QRS, abnormalities of BP waves and blocks. So ECG is a very important tool to diagnose the cause of palpitation. What are the different diagnoses? The narrow complex tachycardia, regular or irregular, it can be AV node independent, sinus tachycardia, atrial tachycardia, unifocal or multifocal, atrial fibrillation, flutter, AV node dependent, maybe AV node re-entry tachycardia, AV re-entry tachycardia, junctional tachycardia. If it's a broad complex tachycardia, it can be ventricular tachycardia or SVT with aberrant contraction. Bradycardia may be heart tissue damage led to aging, tissue damage due to IHD, congenital heart disease, myocarditis, heart surgery, malignancy, inflammatory and infiltrative disease, metabolic endocrine disorders, relations, toxin, drugs, for example, myxedema, hypothyroidism can be there, and drugs like beta blocker or clonidine can also produce bradycardia and chemicals. How do you approach palpitation? Please determine the stability. If vital signs are abnormal, the patient should be moved immediately and monitored bed for further management. Patient should be monitored, and reversible causes such as electrolyte imbalance, thyroid disorder should be investigated and treated. Vital signs should be taken and the patient's overall condition assessed. Medications such as beta blocker, antiarrhythmic drugs can be used to treat stable patients. Hemodynamically unstable patient may require synchronized cardioversion. Now, coming to the syncope or fainting episode, that is also an emergency. Again, this can syncope or pre-syncope or fainting can present in the ED, emergency department. It's a sudden temporary loss of consciousness with loss of postural tone that affects cerebral perfusion, such as changes in cardiac output, systemic vascular resistance, blood volume, or regional vascular resistance can lead to pre-syncope or syncope. Pre-syncope or syncope may be caused by cardiovascular as well as CNS conditions. Different diagnosis: cardiovascular is myocardial infarction, aortic dissection, cardiomyopathy. It can be outflow obstruction like valvular stenosis, hypertrophic obstructive cardiomyopathy, atrial myxoma, pulmonary embolism, pulmonary hypertension, cardiac tamponade, congenital heart disease. It can be reduced cardiac output, maybe tachycardia, SVT, ventricular tachycardia, ventricular fibrillation, Wolff-Parkinson-White syndrome, WPW syndrome, TARS-ADD points. Bradycardia may be sinus node disease, heart block, second or third degree heart block, prolonged QT, pacemaker malfunction, ICD malfunction. Other cardiovascular is aortic dissection, MI, and cardiomyopathy. Now, how do you approach history taking? Again, presence of chest pain, associated breathlessness, is there any cough, any palpitation, onset of symptoms, what are the pre-syncope symptoms, underlying medical condition, comorbidities, use of medication, straining factors, history of previous such episodes, associated symptoms like seizure, loss of consciousness, weakness, emotional instability, toxins, and drugs. Now examination. A thorough physical examination that evaluates all relevant body symptoms to diagnose syncope and identify potential differential diagnosis. You will have to have a proper CNS examination, respiratory system examination, and cardiovascular system examination. ECG to rule out arrhythmia, ischemic heart disease, cardiomyopathy, MI. Echo to see the cardiac outflow obstruction, tamponade, aortic dissection, pulmonary embolism, valvular disease with complication. The management of important cardiac emergencies in the emergency department, most commonly acute coronary syndrome. Acute coronary syndrome includes a spectrum of clinical presentation from unstable angina to non-STEMI or STEMI. Unstable angina is referred as a pre-infarction angina or pre-occlusive syndrome. It's a warning sign of infarction. MI is defined as cell death and necrosis. There are certain criteria satisfying the diagnosis of acute, evolving, or recent MI. The management should be according to the diagnosis. Rise and fall of cardiac markers like symptoms of ischemia, ECG changes, STTV changes, coronary artery intervention, pathological findings of acute MI. Nowadays, we do troponin and various blood markers to find out whether this is a MI. And then ECG, chest X-ray, serum cardiac markers, echocardiography, scintigraphy, and CT angiography, depending on the requirement and availability. How do you manage? Early revascularization and reperfusion using either fibrinolysis or primary angioplasty. So any infarction, acute infarction, the first aim is to do revascularization or reperfusion, either by thrombolysis, fibrinolysis, or angioplasty. Where the PCI is available and cardiology consultation is available, the cardiologist is involved to decide which pathway to follow. Delay in getting PCI does not justify avoiding thrombolysis. For any reason, expected time of PCI is more than 90 minutes, then thrombolysis is the choice of the treatment, and you can follow with PCI later on. This is called pharmacological intervention and reperfusion therapy. The pharmacological intervention, what are the drugs we can give? Like nitroglycerin, it's a coronary vasodilator, reduces myocardial preload and afterload. Pain management in a severe pain, not responding to nitroglycerin and beta blocker. To relieve ischemic symptoms, beta blockers, calcium channel blocker for ischemic symptoms when beta blockers are not successful. ACE inhibitor indicated in patients with left ventricular ejection fraction more than 40 and those with hypertension, diabetes, and stable CKD. Antiplatelet reduces the progression to acute infarction in patients with non-AMI ACS patients, reduce mortality. Of course, anticoagulants are administered in addition to antiplatelet therapy for all patients, irrespective of the initial strategy. Then pharmacological intervention, administer oxygen if blood oxygen saturation is 90% or if the patient is in respiratory distress. Not every patient may require oxygen in a myocardial infarction. Opiates can be given to patients who are not experiencing relief with ischemic symptoms despite treatment with nitrates, beta blocker, while they await immediate coronary angiogram. It is important to note that morphine may hinder the absorption of oral platelet inhibitors in these cases. Reperfusion therapy, either by using thrombolysis, primary PCI, increase the opportunity to salvage the ischemic myocardium. The crux of the matter is you must salvage the myocardium. The more and more time you take, then myocardial death is inevitable. That's why earlier the better to do the reperfusion. Thrombolytic or fibrinolytic therapy improves coronary flow, limits infarct size, and improves survival. Now about the heart failure. How do you manage heart failure? Is defined as the pathophysiological state in which the heart is not capable of pumping sufficient supply. You know, heart is a pump which supplies blood to all over the body. When it gets failed, the blood circulation is affected. It can be associated with cardiogenic pulmonary edema, due to increased capillary hydrostatic pressure secondary to acute ischemia or infarction, cardiomyopathy, valvular heart disease, hypertensive emergencies. In these situations, you get pulmonary edema. And non-cardiogenic pulmonary edema occurs due to alteration in the permeability of the pulmonary capillary membrane. What is the treatment? Stabilization of the patient, resuscitation, identify the underlying and precipitating cause and treat it, control the symptoms and acute congestive state by reducing the cardiac load, reducing pre and after load, controlling excessive salt and water retention, improving the cardiac contractility. Treatments: acute pulmonary edema with adequate perfusion. You can try nitrates, morphine, loop diuretics, nitroprusside, non-invasive or invasive ventilation. In a hypotensive patient with acute pulmonary edema, vasopressors, inotropes to maintain coronary perfusion, manage hypotension due to cardiogenic shock or volume depletion, judicious fluid challenge if low PaOP are less than 15 millimeter. So you'll have to monitor whenever you give fluid change. Even the point of care echo will be useful to see when the IVC collapsed, whether you require fluid or you don't require fluid. You should not over enthusiastically rush fluid. IABP, emergency revascularization if ischemic cardiogenic shock. The treatment of chronic heart failure is manage hypertension. To find out the cause for heart failure, most of the time it may be due to hypertension, it can be vascular valvular disease. So manage the symptom, manage the primary cause, manage hypertension. Reverse remodeling by beta blocker, ACE1, aldosterone antagonist or ARB, vasodilator therapy like ACE or ARB and nitrates. Diuretics, you must cautiously use calcium channel blocker for hypertension, angina, dysrhythmia management, beta blocker therapy, digoxin, especially beta blocker like carvedilol and the newer beta blockers are useful like metoprolol in the chronic heart failure. Then arrhythmias in the emergency department, these arrhythmias can present as chest pain, breathlessness, palpitations, sweating, pre-syncope or syncope or thromboembolic complications. Managing dysarrhythmias in the emergency department is challenging and requires timely intervention. We need proper monitor. And first step in management is to categorize the arrhythmia, whether it's a narrow or broad-based tachycardia or bradycardia, and then stable or unstable. Hemodynamically, they are stable. The type of management depends on the stability of the patient as well as the emergency physician's expertise in managing the system. Because sometimes you may have to cardiovert, so defibrillator is a must in any ICU to tackle dysarrhythmias. Then 12-lead ECG, you can see symptoms and signs of unstable patients in the emergency department, maybe hypotension, features of hypoperfusion, chest pain suggesting myocardial ischemia, dyspnea, pulmonary edema, altered sensorium, sometimes agitation to coma. So management of stable patients, proper assessment, evaluation, detailed history, exam, ECG. Also depend on type of rhythm, whether it is narrow or broad complex. Maneuvers such as vagal, Valsalva can be used as well as medications like adenosine, amiodarone, procainamide, verapamil, and diltiazem. Narrow complex tachycardias can be treated with drugs like slow AV nodal conductions like class 2 agents, beta blockers, or class 1-4 agents, CCB, adenosine, or class 1A, procainamide, and 1C, plaquenil, or can convert them. These are all the drugs can convert them to sinus rhythm. Management of unstable, more aggressively you should do, because unstable patients, they may go for hemodynamic imbalance. Depends on whether it is narrow or broad, wide, complex. The physician's expertise with these drugs and synchronized cardioversion is the treatment of choice. Management options for atrial fibrillation, pharmacological cardioversion, procainamide, propranolone, plaquenil, amiodarone, ibutylide, rate control, verapamil or diltiazem before type 1A agent or beta blocker. Anticoagulation in atrial fibrillation is a must to prevent embolic and thrombotic problems. Electrical cardioversion. In a SVT, you give adenosine, CCBs or beta blockers or electrical cardioversion. Flutter, atrial flutter, pharmacological rate control, beta blocker or CCB. Pharmacological cardioversion, procainamide, ibutylide or amiodarone, and electrical cardioversion. Management options for narrow complex. It is a monopharmic tachycardia or polymorphic with torsady points. For a monopharmic, you treat the underlying cause, amiodarone, procainamide, lidocaine, magnesium sulfate. For polymorphic torsady points, IV magnesium sulfate, beta-adrenergic infusion, amiodarone, and overdrive pacing. CPR techniques. Everyone should know about the CPR technique. Nowadays, we start teaching the voluntary workers, voluntary people, Red Cross people, paramedical people about the CPR because it's going to be a life-saving. If you know this, even in a road, if somebody gets problem, you can try the CPR. What is CPR? The airway, breathing, circulation, disability, exposure approach is a systematic approach to the immediate assessment and treatment of critically ill or injured patients. The approach is applicable in all clinical emergencies. The aim of the ABCD approach are to provide life-saving treatment, to break down complex clinical situations into more manageable parts, to serve as an assessment and treatment algorithm, to establish common situational awareness among all treatment providers, to buy time to establish a final diagnosis and treatment. Suppose we see on the road, you can do this first aid and call for an ambulance, send it for higher centers for further treatment. The ABCD algorithm stands for A is airway, B is breathing, C is circulation, D is disability, rapid neurological assessment, E is exposure. The examination of the patient, you see A airway, B breathing, C circulation, D disability, and E exposure. The examination of the patient starts with approach ABCDE. In case of visible and significant bleeding, we approach the patient according to the principle of CAB. So you should stop the bleeding first. So circulation, then airway, then breathing. The entire patient examination protocol takes place as a team. The ABCD approach is applicable in all clinical emergencies for immediate assessment and treatment. The airway, breathing, circulation, disability is an immediate assessment and treatment of critically ill or injured patients is in all emergencies. The aim is to provide, already told you, life-saving, breakdown complicated. This I am repeating again, to serve an assessment and treating all organisms to buy time. Now, what is A? Airways. Assessment, voice and breath sounds. Head tilt and chin lift. Oxygen, 15 liters per minute and suction. B is respiratory rate, 12 to 20. Chest wall movements, chest percussion, lung auscultation. You always see pulse oximetry and see the oxygen level. Seat comfortably, rescue breaths, inhaled medications, back mask ventilation, decompress tension and pneumothorax. C circulation, look for the skin color, sweating, capillary refill time, less than 2 seconds, palpate pulse rate, heart auscultation, blood pressure, ECG monitoring. So look for if there is any bleeding, stop bleeding, elevate the legs, intravenous access, infuse saline. Disability, level of consciousness, alert, voice responsiveness, pain responsiveness, unresponsive limb movements, pupillary light reflex, blood glucose. Treat airways, breathing and circulation problems, recovery position, glucose for hypoglycemia. In exposure, expose skin, temperature, treat suspected cause. This is the diagram. You see the heart rate. Look at the capillary time to find the circulation, disability, alert, voice response, pain response, unresponsiveness. Exposure, remove clothing. and then head tilt and chin lift. You can see head tilt and chin lift. Look, listen, and feel. That's a breathing. So this is the ABCD of the algorithm. I think every one must know about this first aid measure and significance of heart sounds for the diagnosis of cardiac emergency. Heart sounds are the brief transient sounds produced by valve opening and closure. They are divided into systolic and diastolic sounds. Blood flows through the heart during cardiac cycle and generate 4 heart sounds. A doctor may hear these sounds using a stethoscope. Heart sounds can provide valuable information about the health of the person's heart and may help with the diagnosis. The first and second heart sounds are high-pitched, constitute the heartbeat's healthy lub and tub sounds. The third and fourth heart sounds are low-pitched and may indicate problems with the functioning of the heart. We call it as gallop rhythm. So heart sounds and their anomalies. In the first heart sound, high S1, increased transvascular gradient, increased force of ventricular contraction, tachycardia, mitral valve prolapse. Low S1, inappropriate opposition of the atrioventricular valves, bradycardia, increased distance from the heart. High sound, loud second sound due to hypertension, coarctation, aortic aneurysm. Low second heart sound may be aortic diastolic pressure decreased, improper valve opposition, calcified immobile valves, decreased systemic arterial pressure. S3, systolic and diastolic ventricular dysfunction, ischemic heart disease, hyperkinetic state, systolic dysfunction, systemic and pulmonary hypertension, acute aortic regurgitation, volume overload. S4, ventricular hypertrophy, ischemic heart disease, ventricular aneurysm, hyperkinetic states that cause forceful atrial contraction is the fourth sound. Now, why is metoprolol is preferred in the agent in emergency situation? So I have talked to you about how to approach the acute cardiac emergency, like I told you about chest pain, breathlessness, syncope, palpitation. I was talking about heart failure, dysarrhythmias, etc. Now, a word about metoprolol, because why metoprolol is used in emergency situation. Metoprolol is a cardioselective drug. Selectively blocks beta 1 in the heart without affecting the other peripheral beta 2 receptors. This reduces the risk of bronchospasm, peripheral vasoconstriction, and other adverse symptoms that can occur with non-selective beta blocker. Lipid solubility, which allows it to cross the blood-brain barrier and exert central effects such as reducing sympathetic activity. Metoprolol has a relatively short half-life of 3 to 7 hours, which allows for easy titration and adjustment of the dose. Of course, we have long-acting metoprolol also. The drug is also metabolized primarily by the liver, which makes it suitable for use in the patients with renal impairment. Metoprolol has demonstrated efficacy and safety in various cardiovascular conditions, including hypertension, angina, heart failure, and acute coronary syndrome. Metoprolol is typically started in the hospital setting as soon as possible after a heart attack and may be continued as an outpatient to help reduce risk of future cardiac events. Metoprolol, I told you, reduce the workload on the heart, lowers blood pressure, decrease the heart's demand for oxygen. Reduction in heart rate, contractility, and blood pressure. Consequent relief of ischemic pain, reduce infarct size, reduce mortality. The role of metoprolol in hypertensive emergency, of course, it is typically used intravenously in a situation where the other drugs are not available. Sometimes we use esmolol, labetalol as a beta blocker in emergencies. Metoprolol also can be used. It reduces the activity of sympathetic nervous system, relax the blood vessel, helps decrease the heart's workload, helps to prevent target organ damage. And in a dysarrhythmia is the most commonly used beta blocker in the management of acute atrial fibrillation and flutter in the emergency department. Of course, metoprolol works by blocking the beta 1 receptor located in the membranes of cardiomyocyte, causing decreased excitatory effects at the cardiac level, decreased blood pressure, decreased heart rate and systolic output, decrease the workload on the heart. And metoprolol in cardiac emergencies, in myocardial infarction, it can be used as IV as well as tablets. If emergency, certain places when there is No other choice when you don't have labetalol or esmolol. This also can be used in emergency. 1.25 to 5 followed by 2.5 to 15 milligram every 3 to 6 hours. The only thing is you have to monitor properly. In atrial fibrillation also we can try metoprolol IV, and it should not exceed 15 milligram over 10 to 15 minutes, and you have to maintain with 25 to 100 milligram orally. Then now, having discussed about all the emergencies, now we can take one or two case scenarios. This is a person, a 58-year-old male with a known history of hypertension, non-compliance with antihypertensive medications, presented to the emergency department with complaints of headache, severe headache, dizziness, and shortness of breath. On examination, the blood pressure was 190/110, which indicated hypertensive crisis. The medical history, the patient had a medical history significant of hypertension for the past years. He had been irregular in taking treatment. Physical examination revealed an overweight individual with no significant abnormalities of the system. Lab investigation shows no evidence of end organ damage. So between emergency and urgency, there is an end organ damage. With hypertension, we call it as hypertensive emergency. There is no end organ damage, we call it as hypertensive urgency. How do you treat? Upon admission, the patient was closely monitored. Oral antihypertensive drugs, including lisinopril, amlodipine, and hydrochlorothiazide, were also initiated. Normally, in an hypertensive urgency, we try oral drugs only. And sometimes if they go for hypertensive emergency, because the hypertensive urgency patient also may go for emergency, there we give hypertensive medications like nitroglycerin, metoprolol. Under continuous blood monitoring, you must give. Once you give this, the patient's outcome will be better. Patient was discharged with the comprehensive management. Then you should refer the patient to hypertension specialist for long-term management. So timely intervention and aggressive medical management can improve outcome for patients with hypertensive urgency or emergency. There is a second case, there is another case in angina pectoris, case of angina pectoris, 62-year man with complaints of recurrent chest pain. A described pain as a squeezing sensation in the center of chest radiated to his left arm and jaw. The pain was typically triggered by physical exertion relieved with rest. The patient also reported experiencing shortness of breath. The patient had a significant medical history of hypertension and dyslipidemia, and he was former smoker. On examination, his BP and heart rate were within normal limits. Auscultation of the heart revealed no significant abnormalities, and the patient had no peripheral edema or signs of heart failure. So the resting ECG was normal, whereas when you do treadmill or exercise ECG, there was STT changes, and coronary angiography revealed a significant blockage in the left anterior descending artery, LAD. How do you manage? You can give sublingual nitroglycerin for immediate relief, aspirin, clopidogrel, and also patients should be initiated on metoprolol to reduce the heart rate, decreasing myocardial oxygen demand. Given the significant blockage in LAD, the patient underwent PCI with stent replacement to restore blood flow, because reperfusion is the key. Then the patient was advised lifestyle modification, heart healthy diet, heat management, and to quit sweating, smoking. And in angina pectoris, metoprolol can be given following the PCI procedure when the reduction in the frequency and severity of chest pain. Regular follow-up appointments were scheduled to monitor his progress, optimize medication therapy, assess the need for further interventions such as cardiac rehabilitation, additional coronary interventions. These patients can be put on metoprolol and we can follow up. So metoprolol in atrial fibrillation, a 72-year-old male present with the emergency department, complaints of palpitation, shortness of breath, had started approximately 2 hours prior to arrival. The patient had hypertension, hyperlipidemia, and a prior stroke. So evaluation 150/90, heart rate was irregular. It showed atrial fibrillation. Admitted with rapid ventricular response, heparin drip was started. IV metoprolol was given to control heart rate. Echo showed no evidence of thrombus. Maintenance dose of oral metoprolol and warfarin started, symptoms resolved, and discharge with follow-up instruction. The patient was discharged from the hospital, stable condition with instruction to follow his primary care physician for ongoing management of the ATL. So what is the lesson we learned? Timely intervention, aggressive medical management can improve outcomes for patients with atrial fibrillation, especially those with prior history of stroke or other comorbidities, and we can save lives. So my conclusion is 1 in 4 deaths in India are now due to cardiovascular deaths, with ischemic heart disease and stroke responsible for more than 80% of this burden. Cardiac emergencies refer to life-threatening medical situations that involve the heart and require immediate medical attention. Acute ST elevation or myocardial infarction, cardiogenic shock, and out-of-hospital cardiac arrest are the most life-threatening cardiovascular emergencies. Proper history examination are crucial for narrowing down the differential diagnosis. Appropriate investigations can help the emergency physician to reach a conclusion. Patients presenting with ACS and acute MI should have a timely referral to cardiology for possible early PCI. Patients with moderate to high risk of ACS should be admitted to cardiology care even if the initial labs are normal. Metoprolol has demonstrated efficacy and safety in various cardiovascular conditions, including hypertension, angina, heart failure, and ACS. So, ladies and gentlemen, my dear brothers and sisters, you had been listening to the various aspects of cardiac emergency. The key drive-home message is you should be aware about this emergency. You should suspect based on your history and examination. When in doubt, you always refer, do the relevant investigation, observe the patient. It is always better to err on this side. Suppose somebody you think is normal, but you have a suspicion, it's always better to keep him for a day for observation so that you can save the life. Thank you for your patient hearing. Namaste and good night.